So a woman of 65, sorry, is admitted with easy fatigability, anorexia, weight loss, a change of bowel habit towards a frequent soft stools of 3 months duration. On examination, she was pale, pulse is 100 per minute, BP is 150/60, the chest was clear, and there was a firm, non-tender intra-abdominal mass. Firm. When you say non-tender means no pain. So it's a painless. So a firm, painless intra-abdominal mass in the right iliac fossa. RIF, right iliac fossa. So what I tell people now is, look at it, right iliac fossa. So you demarcate your abdomen. You know, some books can divide into 9 different parts, others into 4 quadrants, just 4 quadrants, others into 9. Okay, so depending on which one you want to use, just begin to imagine the organs that can be found in your right iliac fossa. So assuming this is your abdomen, okay, assume this is your abdomen. So if I'm dividing into 4 parts or into 4 quadrants, this is it. So we have 1, 2, 3, 4. So when we talk about the right iliac fossa, we're talking about organs in this direction. Organs in quadrant 3. Okay, so you need to have those differentials in your head. So talk about every organ that is there. There can be appendix, right? There can be cecum, right? There can be this, there can be that, there can all of those things. Keep them at the back of your mind. That's how to answer your question. All right. So, but don't forget, it is a firm, non-tender. So what is the most likely clinical diagnosis for this scenario? So over here, you know, it can be the appendix, it can be what? The cecum. Okay. But usually appendix is painful. It's tender. Very, very, very well tender. So what it means is that over here, our mind will be drawn to what? To the cecum. The cecum. And that's why over here, we're going to have to call it a carcinoma of the cecum, or cecal cancer. Cecal cancer or carcinoma of the cecum. So that is what would be our likely diagnosis. So indicate the most likely for differential diagnosis. So again, I've told you a lot of organs are here. So you can mention all those organs as possible what? Differentials. All those organs as possible what? As I mentioned a few, but I shall give you a diagram that can give you more details of what I'm talking about. So don't worry, you can get them. So now I'll talk about ileocecal tuberculosis as part of the differential diagnosis. Ileocecal. We can talk about tubo-ovarian mass. So this one will be common in women. Of course, this person is what? It's a woman. So it's very possible. So tubo-ovarian mass can be there. We can talk about what? An ovarian cyst or a twisted ovarian cyst can also be there. And you can think of what? Amoeboma. That is what? Amoeba, or a granulosa of what? Or amoebic granuloma. Called what? Amoeboma. So amoeba, amoeboma. So all of these things can be found in those areas, or they are possible differential diagnosis. But there are a lot. I'll give you a diagram to help you understand it better. So don't worry. But just understand that you can talk about what? The ileocecal, the tubo-ovarian mass, twisted ovarian cyst, amoeboma, and so on and so forth. Now, the reason why I didn't really mention appendicitis is because appendicitis will be very, very painful, but you can also add it to it. It can be appendicitis. Just that appendicitis is what? Painful. So that helps you with making what? A classical diagnosis that appendicitis is definitely what? Not the likely diagnosis, even though it's a differential. Wonderful. Then mention the most useful 3 diagnostic procedures. The most useful 3 diagnostic procedures. So again, it's an intestinal what? Problem. Am I right? Yes. So because of that, you can do what we call colonoscopy. Colonoscopy. You can do an abdominal ultrasound. Abdominal ultrasound. You can do abdominal CT scan. I always tell people, now put this at the back of your mind, since it's the first time I'm dealing with you. So let's put this at the back of your mind. Anytime you are looking for abdominal organs or looking for intestinal organs or things in the intestine, one of the most useful tools you must do is an endoscopy. Sorry, ultrasound. Abdominal ultrasound. Abdominal ultrasound. Then you can add what? CT or abdominal CT scan. Abdominal. These two, you don't go and leave them. And you can even do an X-ray of the abdomen. X-ray. So in that order. So the first thing is what? Ultrasound. Then you can talk of what? Abdominal CT. Then you can think of what? Abdominal X-ray. Abdominal X-ray. Very important. And normally you will do X-ray when you are looking at for a possible how do you call it? Air or fluids or peritonitis, where there will be fluid under the diaphragm and things like that. Perforations, let me put it that way. You can do all those things. All right. So these are the three useful. But for this one, colonoscopy is there, abdominal ultrasound, abdominal CT, and like I said, you can even add abdominal X-ray to it. Abdominal X-ray to it. All right. Then name the treatment procedure of choice for your working diagnosis. So, for example, if it's a cancer, if you don't remove it, it will cause trouble, isn't it? So you just have to what? Remove the cancer. And that is why you have to do what we call a right hemi colectomy. Right hemi colectomy. Don't forget the cecum is part of the what? Of the colon. Or it's part of the large intestine, right? Yes. So the right side, if you take an intestine, for instance, it's something like this, then it goes up, then it comes like, then it comes down like this, something like that. Sorry. Over here, there's stomach, so it must come here around the midline area, where that's the transverse colon. Then it comes down. So ascending, transverse, descending, then sigmoid, and so on and so forth. All right, so you want to remove this first part because that is where the cecum is. So the cecum is here. So you want to remove this whole thing out so that the person will be free. So after removing it, you have to do what we call anastomosis, right? So that everything can still flow like it's used to flow before. So over here, you do what we call a right hemi colectomy. So that is the definitive management or treatment for this patient. If you do antibiotics, in fact, what are you killing? All right. Good. So like I said, I will show you a diagram to help you with it. So anytime you are looking out for the right iliac region over here, think of a mnemonic. I mean, you can use the vowels, for instance, the vowels as a mnemonic for you. So the diagnosis for right iliac fossa mass. Think of what the vowels. So we say the vowels are non-consonant. Vowels are non-consonant. So the A is what? Appendicular mass, ectopic kidneys, ileocecal TB. We can talk about intussusception, but of course, there's some age level that you must know. That's why I'm bringing everything together. So depending on the age, the person, the analysis and everything, then it directs your answer or your differential, isn't it? You can talk about the ovarian abscess, the psoas, undescended testis, non-Hodgkin's, and then carcinoma cecum or cecal cancer. So these things should help you to know what it is you're talking about. In other things, I will show you every single area, which organs are there. I will show you so that anytime they tell that somebody's having a right hypochondriac pain, you know what to look out for. A right lumbar pain, you know what to look out for. Good. So in another time, I shall discuss all of those things with you, but I want to stay in context. So let's move on. All right.
No, please, I have a question.
Please feel free.
Yes. So when I saw the question first, since it's the right iliac fossa mass, I actually thought of the right colon cancer first.
Good.
So,
Good.
but in the presentation, you've not mentioned a right colon cancer. So I want to know the difference, like how in the question are they going to present the right? I mean, yes, are they going to present the right colon cancer?
Good.
Is it going to be in the right iliac or?
Good. Good. Very good. So if you're talking about a colon, right colon. Now, when we say colon, colon is a very big intestine. All right. So like the whole length is a colon. Okay. So like I was saying, so over here, let me draw something over here. Assuming we have the colon like this. So it comes like this, then it moves like that. Okay. It moves like that, and it comes down like this. Then of course you can have your sigmoid, the rectum, something like this. It's something like this. Okay. So the whole of this whole thing is your colon. The whole thing. That's what we say. We have what we call what? The ascending. Ascending also means what? The right colon. So we have the ascending colon, and at the tip of it, that's where you can have the appendix and the cecum. Over here, you can find them over there. Okay. So the whole length is the right colon. This is the transverse colon, and that is the left colon. But the left colon, we have what? The descending. Then we have what we call the sigmoid colon. So they are all what? Colon. So that's why if you say a colon, you are not being specific, because it can be anything. It can be any part of the colon. And what we're having over here, don't forget, even in the lumbar area, there's some part of the colon being there. Do you understand? That is why if you say right iliac colon, then they are expecting you to narrow your answer to organs or to the part of the colon that can be found in that area. Please, are you with me?
Yes.
Good. That can be found in that area. Because if you say right colon, you are correct, but you're not being specific. You are correct, but you're not being what? Specific. Please, I hope I've answered your question.
All right. Yes.
Great.